but protects it. This time, our tech advancements will propel human betterment. This time, we will run the longer race, because the most rewarding pursuit is leaving a world greater than what it is. It was once all about the race. If you weren't ahead, you were out of the game. But when everything stopped, we saw the chance to change the game and begin a new path. This time, the bottom line won't be our finish line. This time, we'll chase investments whose real interest is care. This time, every step we take doesn't just change the world, but protects it. This time, our tech advancements will propel human betterment. This time, we will run the longer race, because the most rewarding pursuit is leaving a world greater than what it is.
I want to see the future. I want to build the future. I want it to be big, bold, brave. To go further, faster. To make the impossible possible. I want to be where the generations of today build the solutions of tomorrow. Investing in cleaner, greener, kinder, smarter innovation. Harnessing the sun, the sea, and the wind, turning the elements to power. On a grand scale. I want to go where innovation saves lives, rebuilds lives, creates life. I want a future built on the shoulders of giants, on a heritage of ideas. It's going to need the right environment. High impact, high value investment. World-class skills. A global vision. I've seen the future. And it's here.
London City, hello.
More women taking over the world.
wonderful.
It was once all about the race. If you weren't ahead, you were out of the game. But when everything stopped, we saw the chance to change the game and begin a new path. This time, the bottom line won't be our finish line. This time, we'll chase investments whose real interest is care. This time, every step we take doesn't just change the world, but protects it. This time, our tech advancements will propel human betterment. This time, we will run the longer race, because the most rewarding pursuit is leaving a world greater than what it is. If you weren't ahead, you were out of the game. But when everything stopped, we saw the chance to change the game and begin a new path. This time, the bottom line won't be our finish line. This time, we'll chase investments whose real interest is care. This time, every step we take doesn't just change the world, but protects it. This time, our tech advancements will propel human betterment. This time, we will run the longer race, because the most rewarding pursuit is leaving a world greater than what it is.
I want to see the future. I want to build the future. I want it to be big, bold, brave. To go further, faster. To make the impossible possible. I want to be where the generations of today build the solutions of tomorrow. Investing in cleaner, greener, kinder, smarter innovation. Harnessing the sun, the sea, and the wind, turning the elements to power. On a grand scale. I want to be where innovation saves lives, rebuilds lives, creates life. I want a future built on the shoulders of giants, on a heritage of ideas. It's going to need the right environment. High impact, high-value investment, world-class skills, a global vision. I've seen the future. And it's here.
London City, hello.
More women taking over the world.
Wonderful.
Good afternoon, mayors, ladies and gentlemen, and welcome to our 6th Livable Cities Lab for this year. Our topic today will be Devolving Public Health Systems, Delivering Universal Healthcare Through LGUs, presented together with the British Embassy Manila and in partnership with the League of Cities of the Philippines and Globe Telecom. This year marks the first or the start of the implementation of the Supreme Court's Mandanas ruling, which effectively increases the internal revenue allotment or IRA in local governments of local government units by 55% in the 2022 budget. Guided by the issuance of Executive Order 138, series of 2021, LGUs now have full autonomy over their nationally funded functions, resources, plans, and projects. In an earlier Livable Cities Lab in 2021, we talked about LGU finance and the Mandanas ruling and how it would create more space for the execution of devolved functions and possible public-private partnerships. In a more recent lab this year, we touched on the Universal Healthcare Law and how it will help provide better healthcare for all. Today's lab will bridge these two topics and explore what would be the cost of providing improved health facilities and better healthcare services for all. And in light of the Supreme Court decision, how LGUs can address health concerns and issues in their communities. As local governments receive more funds and greater fiscal independence, much is expected in terms of improved efficiency, improved delivery of public services in communities, especially the much needed healthcare in underserved communities. Today's speakers include Dr. Vicente Belisario of the College of Public Health at the University of the Philippines, Manila, Dr. Marife Yap of ThinkWell, Dr. Gabriel Borlongan of the Department of Health, and Dr. Ryan Lee from the National Health Service of the United Kingdom. Before we begin our Livable Cities Lab, let me remind you of a few safety tips. First, be aware of your surroundings while the webinar is ongoing in case you need to stop in an emergency. And second, always stay safe and practice social distancing if you are out of your home. Furthermore, just take note, this webinar will be recorded and will be available on the Livable Cities Facebook page. Questions may be asked in the Zoom Q&A chat box, which includes a feature that allows the audience to vote on questions posted by others by simply clicking on the thumbs up icon next to the question. Some of these will be answered directly by our speaker or their staff in the chat box, while other questions will be parked for later in the open forum and answered live. If you are joining the webinar on Facebook Live, you may place your questions in the comments section of Facebook, and our staff will pick it up from there. At the end of this webinar, we will invite you to please fill up our feedback survey. Your response will help us improve our Livable Cities Lab series, and you may also get a certificate of participation by answering the corresponding question in the survey. Okay, so to get the program going, we'd like to ask we'll start with one simple poll question that we ask at the beginning of every meeting. And that question is, where are you joining us from? Your choices, just pick one: Metro Manila, rest of Luzon, Visayas, or Mindanao. So where are you calling, or where are you joining us from? Metro Manila, rest of Luzon, Visayas, or Mindanao? Okay, so we see most of our audience are from Luzon, 40% from Metro Manila, 37% from rest of Luzon, and only 8% from Visayas and 15% from Mindanao. So 23% from outside Luzon and the balance from Luzon. Okay, so let us ask a second question just to prepare for this particular topic today. Here's the second question. Do you think your LGU is ready to implement EO number 138 or the Mandanas ruling, particularly to address the healthcare challenges in your area? Just pick one answer. It's yes or no. Do you think your LGU is ready to implement the EO 138 or the Mandanas ruling, particularly to address the healthcare challenges in your area? One answer, either yes or no. Oh, okay, it's a split, straight split. 50% say yes, 50% say no. Okay, so today, hopefully, we will provide some clarity, some insights, some lessons on how to go about it. And hopefully, you'll come away from today's meeting helping your LGU prepare how to implement the Mandanas ruling. So let's start with our first presenter, Dr. Gabriel Borlongan. He heads the Health Systems Strengthening Division under the Disease Prevention and Control Bureau at the Department of Health. This bureau is in charge of leading the development of integrated disease prevention and control strategic plans and monitoring and evaluation frameworks for primary care services, investments, and capacity building on sectoral and organizational perspectives. So to present on the topic, expanding health services and infrastructure development across the region, let's please all welcome Dr. Gabriel Borlongan from the Department of Health. Dr. Gabriel, the floor is yours.
Thank you, Sir Bill. So good afternoon to everyone here. Thank you to the Livable Cities Challenge and its partners, the British Embassy and Globe Telecom, for inviting the Disease Prevention and Control Bureau of the Department of Health to give a talk regarding how we could expand health service delivery through primary health care. So for a brief overview, Executive Order 138, or the full devolution, was prompted by the Mandanas ruling. In a nutshell, this enables local governments by receiving a greater share from the national funds. This will give the local government a wider fiscal space to exert the functions vested upon them, empowering them to deliver services to their constituents. On the other hand, the role of the national government is re-emphasized to set national policy, develop strategies, and service delivery standards. The link between the two is the national's assistance, oversight, and supervision over the local actors' performance. But as Spider-Man's Uncle Ben always says, with great power comes great responsibility. With more resources, how do we invest smarter to reach our Ambition 2040? Let us step back in time a little more than 3 years ago. A landmark law was enacted, the Universal Healthcare Act of 2019. This sets into place the shift on how we deliver, organize, and finance health services so that every Filipino has access to quality healthcare without experiencing financial catastrophe. Among the key reforms ascribed in the law are primary healthcare, integration of local health systems into province-wide and city-wide health systems, and setting predictable and precise fees. Proximal to service delivery, what we would focus on is primary healthcare. When we transition to and institutionalize primary healthcare, we will see a shift in direction of delivering health services. Traditionally, most of our strategies and plans are disease-specific. Eliminate malaria, control tuberculosis, reduce malnutrition. This meant setting up a program for each disease or condition. This actually sets us up to disaster in the long run, as the pace of increase in the number of human health workers cannot keep up with the number of programs being set. As for the general population, we usually seek care when we are sick, with doctors and facilities paid when patients are treated, instead of the number of patients prevented from coming into the hospital. Now, in the UHC law, we focus on the primary healthcare approach. It leans towards preventive and promotive health we act on before a person gets sick. This approach includes lifestyle and population-based approaches through a community-wide effort to prevent diseases. It shifts the main actors from just doctors and nurses and hospitals to an integrated approach, not just from the health sector, but also involving other sectors and the whole community to make everyone healthy. Why this shift? Several studies have shown that direct health services only has a limited impact to one's health, around 20%. But when we look up, we have overlooked other factors, the determinants that lead us to sickness. These are so-called the social determinants of health. For example, for the impoverished without stable jobs, who could not afford to buy healthy and nutritious food, they will probably get sick not once, but frequently. If you live in an unsanitary environment, the more likely you are to get infected with various ailments. Healthy behaviors are shaped from our habits. A person's habit is formed by the community, the family values, education level reach, the culture that they have grown with. Hence, health promotion would largely influence this part. So when we look at it, the health sector providing health services only comprises 20% of our health. It happens when people already got sick, while this 80%, if we focus on this and engineer the ways to prevent people from getting diseases, then the more likely we are for our people to be really healthy. In this new focus on a preventive approach, we could actually save more people, and even more money. If a person gets sick, hospital bills and medicines are more costly. And this is not just a proposition. In the US, healthcare markets with a larger percentage of primary care physicians have lower overall spending and even a higher quality of care. But again, more than these savings, we save lives, improve them, and when they are healthy, we would lead them to a more productive life. Now, when we say about primary healthcare, it involves a bunch of components. It starts about integrating services around the person. Traditionally, we had separate programs, but now we want to integrate these around the recipient so that all services could be delivered where applicable. It involves promoting mental health, getting screened for tuberculosis, maintaining oral health, managing your hypertension, avoiding animal bites and other infectious diseases in just a single or few visits and with your primary care team. Think of it as a one-stop shop in order to optimize our resources. But in being a one-stop shop, we do not limit ourselves to be inside a facility. It doesn't have to be a single person. It may be a team. As we have seen in the pandemic response, we have to be innovative in how we make services more accessible by being mobile, whether virtually or going to where the people are, and even across multiple sectors. The vaccination program has demonstrated the extent of participation and task shifting involved with people who do not traditionally perform health services or related functions. Integration is the name of the game moving forward. If primary care is the gateway, it has to connect to a network of providers. Especially in cities, higher levels of care are abundant, from hospitals to even specialty clinics. Investing in a primary care focused system should be complemented with connecting your referral network. Excluding emergency concerns, people would have to go to a primary care facility to be evaluated. For simple cough, diarrhea, hypertension, one could be immediately diagnosed and treated. There is no need to get admitted. But we have to take into account that with the thousands of diseases, a doctor at the primary care level will still definitely need to refer their patients to specialists or for examinations that are not readily available. If we are to gain the trust of Filipinos and influence the behavior to start going to primary care, while ensuring that when they need further assistance, they will be navigated, you would not have to see the typical scenario of overcrowding in tertiary hospitals, overburdened hospital health workers, leading to slower or lower quality of services. We can fix this by integrating health services, health facilities with the people in mind. Going back to the social determinants of health framework, delivering care is just 20%. We still need to tackle the aspects of environmental health, safe settings, the areas where we practically live, work, and experience life to the fullest. In health promotion, we have to tackle the 7 priority areas, not only through advertising and infographics or publicity materials. Basically, we want to shape a society where people choose to live healthy and to make healthier decisions, whether it be from diet and exercise, environmental health, vaccines and immunization, substance use, mental health, sexual and reproductive health, or violence and injury prevention. These factors will shape the trajectory of our risk from getting sick. But if health promotion is not just about communication, what does it entail? It entails a whole of government and the whole of society approach for people to make healthy choices. Building healthy public policy is not just at the national level, but with the power to create ordinances and local executive orders, local governments can pave the way in creating supportive environments, strengthening community action. These efforts are very local. As we implement, we have to drive these efforts home towards developing personal skills and reorienting health services towards self-care and a good health-seeking behavior. A livable city is a healthy city where the local health board invests in primary care, especially the healthcare workers and their tools, and primary care facilities, where local health offices actively shape the services for care and cure to be integrated, and engages and connects with providers and facilities across the metro, whether they be a big private hospital, a pharmacy chain, or clinic. A livable city is steered by the local chief executive and city council for policies and environments to be planned and molded so that people actively choose health and participate in building a healthy Philippines. That's all. Thank you.
Thank you, Dr. Gabriel. I like the approach that you have just described. One of, I guess, personal responsibility being one. Second, that recognizing that we have other factors at play in the health of a person. It's not only health services, but the behavioral factors and the socioeconomic factors. And third, that you've talked about, a livable city is a healthy city. And I think what city residents would look forward to is that aside from taking a very personal approach to their health, knowing that they can count on the facilities of a city or a province to be able to tend to them should the need arise. And that's why primary healthcare is so important. So thank you for that, Dr. Gabriel. And we hope to get back to you with some questions a little later on during the open forum. Our next speaker is Dr. Vicente Belisario. He is the current Dean and Center Director of the College of Public Health at the University of the Philippines, Manila, or UP Manila. And prior to his appointment as Dean, he served as Undersecretary of Health for Technical Services. Dr. Belisario is a medical doctor with training and expertise in tropical medicine and public health. He served briefly as the regional focal point for neglected tropical diseases at the WHO, or World Health Organization, Western Pacific Regional Office. His scientific work has been shared in local and international journals on topics such as malaria and neglected tropical diseases or infectious diseases born out of poverty, which have provided the basis for the development of global and national policy and enhancement of service delivery. To speak to us about partnerships for better health, better public health systems, let's please welcome Dr. Belisario. Doctor, the floor is yours.
Thank you, Mr. Luz, and I wish to share my screen. And a pleasant afternoon to all. Thank you to the organizers for the kind invitation from Livable Cities Challenge Philippines, requesting us our thoughts on strengthening local health systems and delivering universal healthcare through partnerships. And when we talk about universal healthcare and the need for partnerships, I can't help but talk about public health. Now, we talk about organized efforts and informed choices of society, organizations, public and private communities and individuals. Quite different from clinical medicine that is focused on diagnosis and treatment, no? and a bit of prevention. Getting people who are sick to be well and better, avoiding continuing morbidity and mortality. In public health, we wish to be able to provide maximum benefit for the largest number of people. 100 years after the originator of public health, Winslow, in 1920, we realized, especially after continuing major public health challenges, now still in our midst, with COVID-19 pandemic realized and an ongoing brewing pandemic, all of us wishing it to be just endemic, we realized the continuing high relevance of public health 100 years after Winslow. In public health, we talk about the importance of describing the problem, using evidence, looking at risk factors, identification, again using evidence, and actually coming up with interventions, evaluation, again using science and evidence, and we implement the solutions strategically from problem to response. Public health actually requires data to provide the evidence and basis for timely and adequate response to major public health challenges like COVID-19, along with other challenges that I will mention in this particular talk. What are the priorities in public health? And in public health, we cannot say we will do everything. With limited resources and limited time, limited human resource, and limited efforts of all concerned, even our partners, we wish to be able to prioritize, and that is dictated by our higher authorities among the United Nations. We talk about sustainable development, and we target 2030, where we actually aim to be able to address 17 goals with the United Nations setting up an urgent call for all developed and developing countries in a global partnership towards ending poverty and better health, ending poverty and other deprivations, going hand in hand with strategies that improve health and education, reducing inequality, and spurring economic growth, all while tackling the emerging challenges related to climate change and working to preserve our natural resources. Dr. Gabriel Borlongan mentioned our Ambition 1920-40, which actually expresses the Philippines embracing the SDGs, a long-term vision for the Philippines, where we wish to leave no one behind, realizing the Philippine ambition of a life that is matatag, where we have strong family and community ties, maginhawa, comfort, and panatag, peaceful and secure. 17 of them, a number of them are actually touching on health. Our target date is 2030. Note that the 17th goal talks about partnerships, which is a topic that has been assigned to me. What are the top priorities and targets? Let's go to the Global Sustainable Development Report of 2020, where the authorities have declared this decade from 2021 to 2030 the decade of action to deliver the Sustainable Development Goals by 2020. A very critical period to advance a shared vision and accelerate responses to the world's gravest challenges, from eliminating poverty to hunger to reversing climate change. Note that the novel coronavirus has turned into a public health emergency, into one of the worst international crises of our lifetimes, changing the world as we knew it before the pandemic. The Sustainable Development Goal Report of 2020 presents some of the devastating initial impacts of COVID-19 on specific goals and targets. And this local governments must understand, as this has set us back so many squares, delaying now our achievement of the goals in 2030. A short list of indicators are actually included in the scores for the Philippines, where SDG 3 indicators are actually close to the targets, just few of them. Compared to other countries in the region, the Philippines is far from reaching some targets, such as targets for reproductive, maternal, nutrition, neonatal and child health, non-communicable diseases, and we have lots and lots of these, as well as urban and environmental health. We have our old assignments. Gaps exist in infectious diseases, prevention and control. The Philippines having one of the highest rates of tuberculosis. We hear from the experts we're number 4 in the whole world. TB incidents in the region. A continuing increase in HIV prevalence might be further monitored. Relatively large inequities in skilled birth attendance, neonatal and under 5 mortality, and the adolescent birth rates have been identified. A bit more data. The next couple of slides talks about our scores as far as the major indicators are concerned, health indicators are concerned. Note that it is ideal that we have a green score, more than 70%. Okay with your yellow, but of course we don't like the orange, less than 40% proximity from target. We're not doing well as far as maternal mortalities are concerned. Doing quite well with under 5 mortalities and neonatal mortalities in the recent years. Not doing well for the proportion of married or in-union women of reproductive age having their need for family planning satisfied with modern methods. Adolescent birth rates at yellow. Vaccine preventable diseases at yellow. Now they should be green already, especially after the major victories in the last several years. TB incidence is orange, doing not so well. We're doing quite okay with malaria. NCDs, where the regional average is about 17.1, we score a high 28.6 and we need to do something about it. Doing quite well in terms of age standardized prevalence of tobacco smoking among persons 15 years and older. Mortalities related to household and ambient air pollution, yellow. Mortality rates attributable to exposure to unsafe water, sanitation, and hygiene related to the infectious diseases of poverty, we're actually still yellow. And in terms of skilled health professional densities at 42, note that the world is falling short overall, no? Not just the Philippines, on its promise of universal health coverage by 2030. We see, based on the evidence, that there is rising out-of-pocket health expenses, no, quite the opposite direction compared with the goals of universal health care, reaching unsustainable levels, pushing millions into extreme poverty. And as such, with the tremendous challenges in public health, universal health care, and the need to strengthen our local health systems, we do need to maximize the partnerships to achieve sustainable development. Pursuing sustainable development requires an ambitious approach that gets everyone behind the goal of leaving no one behind. Involving the different stakeholders today in a very concrete way will determine the attainment of the SDGs in the remaining 8 years and on to the year 2040. If I may summarize the major public health programs in time of COVID-19 and the now normal, we've experienced so much disruption in delivery of health services. This will need to be addressed by our frontline local government units, a decentralized health system with varying levels of capacity to spearhead delivery of public health services, and thus a major need to continue to ensure that there is continuing capacity building of our local health workers. Delays in the reaching targets of the UN Sustainable Development Goals, and in time of pandemic and now normal, a need for more than business as usual, a need for catch-up and acceleration towards meeting our targets. May I add, a need for strong health communications, sharing facts versus fallacy, what works versus what doesn't. And we know for a fact how not so good communications can break health programs in the last several years. And that we experience up to now with vaccine hesitancy and misinformation. And as such, public health is not easy, but quite challenging, but offering tremendous opportunities to help so many, in fact, millions and millions of Filipinos. Now, this I borrow from the Institute of Medicine, the need for partnership in public health, responding to major public health challenges like COVID-19, where government actually starts these all in terms of policy at national level and frontline service delivery by our local government units. We have the communities as our targets, the clinical delivery system, the diagnosis and treatment in clinics and hospitals, just part of the overall scheme. Our employers and businesses playing also major roles in terms of providing healthy workplaces, the media providing hopefully the right information so that all of us help ensure the conditions for population health. A short note on academia, which I represent in this forum, we're tasked to do education, training, research, and public service, the ability to provide capacity building, the ability to provide technical support, not just for local government units, but even to partner to Department of Health and concerned agencies in pursuit of ensuring the conditions for population health. And as such, public health requires a tremendous amount of partnership and collaboration. Nobody can do it alone. Just a quick note on my institution, the UP College of Public Health. We're celebrating our 95th anniversary this year, closing in on our centennial 5 years from now. We're also the Semiotrope Regional Center for Public Health, Hospital Administration, Environmental and Occupational Health, tasked to take charge of education training of public health professionals in the Philippines and our neighboring countries in Southeast Asia, generating evidence through research, hopefully providing the evidence for policy and enhancement of service delivery, and public service by way of technical support to national and international agencies, to include local agencies like local government units, continuing education. When I took over in 2019, we were tasked to actually prioritize sustainable development, providing now thematic areas for academic programs, research, and public service. We realized that the very difficult road ahead, and as such, we declare we cannot do this alone. And as such, last year, we conducted a quick survey of the landscape of academic public health, because we know for a fact that there's going to be so much need for capacity building in public health, especially that we have realized the first pandemic in our lifetime. We did a survey of Luzon, Visayas, Mindanao, and different schools offering undergraduate public health, graduate public health, graduate courses with public health track and Doctor of Public Health. Our major findings: the majority of academic programs are offered in Luzon, with very limited number of institutions offering undergraduate public courses in relation to the demand for higher education in public health. Our graduate level programs for public health are only in selected regions, limiting the opportunity for training of public health policymakers and managers at regional, provincial, and city levels. Very limited doctoral level programs to contribute to science and growth of the field in the context of low middle income country like the Philippines. And as such, we saw the need to bring together academic institutions, we call them higher education institutions in public health, bringing them together to set up now the Philippine Academic Consortium for Public Health, tasked to help each other now to respond to the needs for health human resource capacity building. 7 institutional founding members, where we now focus on helping the Philippines by way of offering public health in the new normal towards sustainable development. Great role of HEIs in achieving the health-related sustainable development goals. And notice that we in academia are also doing partnership with each other, realizing the very difficult road ahead and the need for us to help each other out. Health human resource development, tremendous needs in public health human resource development. For a start, the Department of Health has tasked UP, and we will bring in the Academic Consortium for Public Health, so that we have capacity now to help the other universities join in and carry the load of training our health promotion officers from the different regions, provinces, cities, and municipalities. The requirement to come up with epidemiology and surveillance officers in regions, provinces, cities, and municipalities. These are all required by universal health care. And when local governments get the invitation from the Department of Health, be sure that you recommend your scholars to undergo training with the universities. Zwillig Family Foundation, a private partner, will now focus on health leadership and governance, capacity building, as well as equity in health, deriving evidence to actually reach the unreached and serve the underserved. Public and private sectors, therefore, have a role to play by way of contributing to health human resource development, the future of public health in the Philippines, the future of local health system strengthening, delivering universal health care. In summary, may I offer my reflections on strengthening local health systems, delivering universal health care to score big in public health. First, our health priorities and targets are provided by the United Nations Sustainable Development Goals. You saw the scorecard. We know where the Philippines lags behind. Let us focus on them. Who? Local government units, health human resource, the crucial role of local government units in delivery of quality health services consistent with universal health care. And how we need to strengthen local health systems delivering UHC as the way forward in the now normal, focusing on capacity building, building the future of public health service delivery in the Philippines, and generating the evidence for enhancing policy and service delivery. And last but not least, the crucial role of higher education institutions in public health, which I represent today, as well as our partners, we cannot do this alone, in health human resource development and provision of technical support to local government units, Department of Health, and other concerned agencies to help meet targets for sustainable development. There are tremendous challenges, but also tremendous opportunities for public health in time of COVID and the now normal. We call for enhancing partnership and collaboration in public health now more than ever. Maraming salamat sa inyong pakikinig. Isang mapagpalang hapon po sa ating lahat. Over, Mr. Luz.
Thank you. Thank you very much, Dr. Belisario. You really laid it out as to the necessity of what we all need to do. And I think just coming from this situation of COVID, and even, we're just entering that endemic state. But for the last 2 years, I think we've really felt the need for a strengthened public health service, starting, as you said, with the need for data and lots of data, timely data, to be able to make decisions. And I like how you tied everything to the SDGs and to Ambition 2040. I think those are great targets, and I didn't realize that 11 of the 17 SDGs had, health played a role in across those SDGs. What is disturbing, I think, is that while we've all been focused on COVID, we've seemed to have forgotten what the other basic problems were. Maternal mortality, adolescent birth rate, the NCDs, the diseases which can be prevented by a vaccination program. We might be falling behind in that. TB, even water and air quality. I'm surprised that played such a big factor. So it's a lot of things we need to do. But you're right. I think what people are looking for is healthcare delivery, affordable healthcare delivery. Because as you correctly pointed out, there are rising out-of-pocket expenses for individuals. And this causes worry, I think, for a lot of us, and the fear of getting sick and hospitalized. And finally, the need for better communication. So thank you for this, Dr. Belisario. We wish you all the luck in building up your consortium, and may it grow and expand, because we need more public health specialists. So we look forward to having questions given your way during the Q&A. So thank you very much. Now let's move on to our next speaker, Dr. Ryan Lee. He is a Senior Health Systems Advisor of the UK, United Kingdom National Health Service Consortium for Global Health. He oversees the UK NHS technical inputs to the Foreign, Commonwealth and Development Office Better Health Program in Southeast Asia, Latin America, and South Africa. In his former roles at NICE International and International Decision Support Initiative at Imperial College London, Dr. Lee led on health technology assessment capacity development projects in Southeast Asia, including the Philippines. So he has some familiarity already with the country. He will be speaking to us from London and joining a little later on during the question and answer period. Dr. Lee will speak on global partnerships to deliver universal healthcare, a case study for the Better Health Program. Let us all please welcome Dr. Ryan Lee from the UK National Health Service. Dr. Lee.
Eu vejo que a saúde no Brasil tem três grandes problemas, né? O primeiro é o acesso, o segundo aspecto é desigualdade e o terceiro é custo. E a saúde digital, ela responde para esses três problemas.
A medicina à distância.
So we've just seen a video from the Better Health Program, Brazil, funded by the UK Foreign, Commonwealth and Development Office, FCDO. Many of the challenges in the video will be familiar to many of us in the Philippines and other countries. It highlights many of the health system challenges faced by local communities that are working towards universal health coverage. And I'm Ryan Lee, Senior Health Systems Advisor for the UK NHS Consortium for Global Health. And as the National Health Service, we represent over 70 years of experience implementing universal health coverage in our country. And in the next 10 minutes or so, I shall be sharing some of our experiences working with country partners through the Better Health Program across 8 countries. So the Better Health Program is very much part of the UK government's efforts to work with countries overseas on building global health partnerships towards universal health coverage. And our Foreign Secretary recently published this position paper, Health Systems Strengthening for Global Health Security and Unity. And I quote, through our joint UK government efforts, we will strive to strengthen and build mutually beneficial international partnerships. So we can share the best of UK expertise, but also learn from other countries' experiences, a win-win for all parties involved. And the Better Health Programme has exactly been that lever or portal for sharing global knowledge and learning, generating evidence across countries. They may be at different points of their journeys towards UHC, but they all have the same goal in reaching cost-effective, affordable, high-quality care for all, whether at the national level or in the community or city level. And what we've been able to do from the UK National Health Service Consortium Global Health is to bring together expertise from across our national health bodies, as well as local health bodies, as well as professional institutions and academic institutions, representing different areas of health system strengthening, and brokering those opportunities to share knowledge with our partner countries. So you can see a whole scope, whole breadth of topics relating to UHC that we have been able to support in the Better Health Programme. So from work in Mexico, facilitating twinning between one of our local government agencies, Bradford, with a province in Mexico, on the whole systems approach to obesity prevention, to work in South Africa, which is looking at how to monitor and use digital health information systems to do surveillance for diabetes in South Africa, and closer to home in the Philippines, where the NHS really has been supporting a whole range of work streams with LGUs, including Pasig City and Iloilo City, on supporting local NCD policy planning, implementation of clinical pathways, digital health, health technology assessment, and so on. And this represents just some of the breadth of the national health bodies that are part of the NHS Consortium for Global Health. As I mentioned, really representing the whole spectrum of capabilities required for health systems, whether national or local, to develop and design and implement UHC. And we operate primarily through a model of knowledge exchanges. So in the pandemic, that has meant a lot of virtual workshops and webinars with experts, very senior level experts from these institutions, engaging in direct peer-to-peer conversations with health officials and senior policymakers in our partner countries. And I want to use the Better Health Programme Philippines as one of our best case studies of how global health partnerships can really help to enable cost-effective and sustainable UHC. So this really was kick-started with a series of virtual knowledge exchanges between the DOH in the Philippines and the UK National Institute for Health and Care, National Institute for Health and Care Excellence, NICE, in the UK. So this is the institution responsible for developing clinical guidelines and approving new drugs for reimbursement in the NHS UHC coverage, based on cost effectiveness and other evidence-based criteria. And actually this collaboration between NICE and DOH dated all the way back from 2012. This through the Better Health Programme since 2019 that this relationship has been rekindled. And the timing is really opportune because in November, as many of you will know, the DOH published its first national HTA methods and process guidelines under the UHC law, and that contained kind of many references to NICE methodology and advice and tools. And really the ultimate aim is to ensure that medicines reimbursed under the UHC scheme under PhilHealth are good value for money. Now, the Better Health Programme has brought that national policy piece together with the implementation at the local level, and this is where the LGUs come in, and that's really the core of the work delivered by delivery partners on the ground in the Philippines through the Better Health Programme, our partners over at PwC and FHI 360, with support from the British Embassy. So at the LGU level, delivery partner has been designing and implementing local HTA training courses and clinical pathways. So that really provides some complementary technical input and academic input from other UK institutions as well, such as the London School of Hygiene and Tropical Medicine and University of Glasgow. And kind of this is all really bringing together all of the different strands of local initiatives in NCD and health policy planning, and kind of really enriching that idea of a local learning network with a tangible policy and clinical directive under health technology assessment. And so kind of the training courses is one element feeding into that. So in short, the Better Health Programme Philippines, it has been about all of these national to national partnerships at government level, local to local partnerships, and academic to local partnerships, and making those links between local and national. And it is kind of these different linkages and connections that have made the Better Health Programme Philippines. Well, so far it's been successful in terms of the engagement of our value partners at Iloilo City and Pasig City LGUs. And to date, the institutional partnerships continue both at the national level between DOH and NICE, and also at the LGU level, kind of with some final year activities to help program sustainability as the program goes towards its kind of final months. So to conclude, the Better Health Programme has really been a unique health development programme in how it's brought together global health partnerships at each level of the health system. In particular, the government-to-government level engagement facilitated by FCDO and the NHS consortium, combined with the delivery partner-led efforts at the local community level, working together with local governments and health institutions to empower local policymakers and to co-design health programs and policies, and to build local capacity towards universal health coverage. It's really that collaborative efforts of the different levels and the different partners, different sectors across the different countries, that I think has been really instrumental to the success of the Better Health Programme so far. And as we enter the final year of the Better Health Programme, we're really looking forward to seeing some of the results from the programme, especially the efforts in scaling up some of the local initiatives, like the likes of the NCD planning and policies that have been implemented in Pasig City and Iloilo City LGUs, and seeing some of those efforts being really spread across other LGUs as well. And I think one learning we have taken from the experience of the Better Health Programme is that actually all countries and local health systems have a lot to offer each other in terms of what they have achieved, or some of the facilitators and barriers they've encountered in their journey towards universal health coverage, and in attempting to sustain those efforts. The same is true whether it's a village in the Amazons in Brazil, or a city in the Philippines, or a deprived area in England. I think there are lots of common challenges, and the solution in each setting may look different, but there are some common principles, and it's always useful to learn from mistakes and not to repeat what others have done, when it could be something better or more efficient could be done in your setting. And I think that's where I really have to say, in the UK, where we have many years of experience, we are still learning. We face, especially in our cities, we face growing NCD burdens, like many cities in the world, with aging populations, and many of the challenges around that, around health financing and around health and social care and capacity challenges with the health, human resource for health. So I think there are lots of ways we can all learn from each other and do better. And I think there's a real opportunity here in the Philippines, with the successes of the Beth Health program seen so far in the two LGUs in particular. So my final point is that local health systems can really be trailblazers. They can be the champions in these health system innovations to tackle NCD burden and to really strive towards universal health coverage. And they can be the champions for good practice and to seed these good practices across the nation of the Philippines, across the ASEAN region, and potentially globally. And certainly the Beth Health program with the 8 countries provides a platform to share that learning. And from the UK, the NHS consortium will very much be keen to continue becoming or being your partner in that knowledge sharing effort and that learning efforts. And let's walk this journey together towards universal health coverage. Thank you very much, and very much appreciate the opportunity to present this workshop. Be happy to take any questions via the Q&A later in this webinar, but also via email as well. Thanks again.
A PS digital para nós foi sonho. Isso para nós é uma felicidade muito grande. Santarém, assim como todos os outros municípios no Brasil, tem muita dificuldade para conseguir médico. Pela questão de localização, acesso, pelas dificuldades que são encontradas para quem vem para trabalhar no interior. E a APS digital, eu tenho certeza que está vindo para melhorar. Pela experiência que nós já tivemos, os pacientes que foram atendidos, pela satisfação da nossa população, nós entendemos que talvez essa seja a solução para onde não tem médico.
Thank you very much, Dr. Lee, for your presentation and for guiding us through the examples of partnerships. I think what's valuable is that your experience across 7 or 8 countries in the Better Health program, countries like Mexico and Brazil, South Africa, but closer to home here in the region, you have Thailand, Vietnam, China, and of course the Philippines. And I think you illustrate well how partnerships work. And I think what's good to see here is not only national to local government partnerships, but you're correct. There's a lot to learn from one local government to another local government. And I think that your work in Pasig and Iloilo is showing great results, because if I were to take a look at the vaccination coverage and the response they had just on COVID alone, certainly they were among the top performing cities in the country in terms of providing the first 2 doses, the primary series of vaccinations, and the and even boosters, not only for their city but for neighboring cities. So thank you very much, Dr. Lee, and we look forward to having you on board during the Q&A. Now let's move on to the last speaker for today. She is Dr. Marife Yap, a physician by profession and a teacher and social development worker at heart. Marife is currently Senior Technical Advisor at ThinkWell, based here in the Philippine Country Office. ThinkWell is a health systems development global organization focused on helping low and middle income countries achieve universal health care coverage. Currently, ThinkWell is implementing the strategic purchasing for primary health care project in the Philippines. And well, Marife and I go back all the way to her college years, though I had not seen her for a long stretch of time until COVID came along. And then suddenly we found ourselves working on a near daily basis, certainly a weekly basis, on COVID response across a wide range of fronts. So it's my pleasure to welcome Marife here to the Livable Cities Challenge to talk about a holistic approach to universal health care. Marife, the floor is yours.
Thank you, Bill. So good afternoon to all, and thank you very much for extending this invitation. The topic is a tall order, holistic approach to universal health care. But I thought that in the interest also of the limited time given to me, I would like to focus on how we could possibly take advantage. And when we say we, I say local government units, take advantage of what I feel are 2 great opportunities that are given to local government units to really do something for the health sector, especially for the health and well-being of their constituents. I think I will just share my slide because I will try to see if I can move this faster. So, okay, so I hope that you are able to see my slides now. Can I just get a confirmation, Bill? Can you
yes,
see my slide?
Now we can see it, yeah, full screen. Okay. Thanks. Marife, go ahead.
All right, yeah. So I thought that we could try to look at what are opportunities and challenges that both the Universal Healthcare Law and this Mandanas-Garcia ruling offers to local government units. I know that you've already heard from Dr. Borlongan and of course Dr. Belizario and Dr. Lee about many exciting possibilities. And I suppose Dr. Borlongan was able to share with you what the Department of Health in itself is also trying to do in order to actually align their work and their programs, particularly from the Health Promotions Bureau, to be able to make sure that the transitions related to Universal Healthcare Law implementation law are seamless. And so we have already talked about this. It's been mentioned very frequently, and I know that the Livable Cities Challenge Fora have already discussed both the UHC law and the Mandanas-Garcia ruling on separate occasions. But if you could just allow me to run through certain important and key points that these opportunities provide us. So first, why did we have to do a UHC law? Because there are many issues in relation to how healthcare was delivered and how healthcare is purchased or paid for in the country. And this first column shows us what these issues are. So confusing membership or prioritization and all down the line. Why do we want to change this? Because all of us desire for every Filipino to be prevented from being sick, and these are the health promotion programs. But if this Filipino or Filipina gets sick, he or she is managed well, meaning that he or she is seen by a healthcare provider, seen at a facility, treated sufficiently, provided medicines. Therefore, a health system that is truly responsive so that we can achieve that which we have long desired for, which are good health outcomes. But also, in addition to this, protecting our people from becoming poorer because they needed to purchase medicines or get hospitalized, and therefore ensure financial protection. And how does the Universal Healthcare Law do this? Basically, it is through integration. Integration that happens in the area of simplifying the membership types. And I will not dwell on this too much because I assume that your previous sessions or previous speakers have already delved on this somehow. So simplifying to the directly contributing and indirectly contributing members, but more importantly, emphasizing that by virtue of citizenship, everyone is a member of the PhilHealth, which is our social health insurance organization. Then we talk about highlighting primary health care and emphasizing public health through synergies that we hope to achieve in the provinces and cities through a province-wide or city-wide health system. Therefore, I think you already know that one of the first big salvos of universal health care implementation is the Consulta, which is a package of outpatient primary care benefits that are available to all citizens or all members of PhilHealth. Then we want to highlight a technical integration, which is largely what Dr. Borlongan talked about, that through the province-wide or city-wide health systems, we have healthcare provider networks, which hopefully will be able to engage private sector participation in the delivery of the range of health services, which are not anymore vertical in orientation, but along the life stages. So that is the reason why there is a shift that was emphasized or shared by Dr. Borlongan earlier. And then, of course, we want to manage this in an integrated way. That's why this opportunity to talk to many local government units is something that I wanted to take advantage of, because here I'm showing you really, as what Dr. Lee himself told us, the local health systems have the capacity to innovate. And what I'm saying here is the UHC law is actually really highlighting how truly important it is that the local government units lead the way in making sure that the universal healthcare law policies and guidelines get implemented at their level, because now the local government units are the frontline health service deliverers, and units, central units like the DOH are technical support that will be able to provide the way for the LGUs to actually carry out the proper system organization that will deliver the services that the people need. And of course, the third level of integration has to do with the financial integration, which is the pooling of funds into a special health fund. And I know that to many of you, these are the juicy topics that you wish we would discuss further, because these are important matters at the level of the local health board and the decision makers at the LGU. And so, again, just to remind everybody that UHC does not mean lahat libre. UHC does not mean that now that we have the UHC law, Filipinos will not draw anymore from their pockets in order to pay for services. What we're saying is that the UHC law makes sure that every Filipino family is matched to a primary care team who ensures that there is appropriate services that are given and received through an appropriate facility. I'm highlighting here appropriate, because we are, by tradition and by orientation, we're so used to just saying that healthcare is accessed in a hospital. We got used to that anything we need, we run to the hospital. But that is not exactly the case, because in the continuum of health services, we have what we call the primary care services, which are actually services that span preventive, promotion, public health programs, which are offered in an outpatient basis. So an appropriate facility given by the appropriate primary care team. And in so doing, the Filipino family's health spending becomes predictable, and PhilHealth, which is our national health insurer or social health insurance program, will ensure that Filipinos are protected from financial risk. And so you've already heard this in your previous UHC sessions, I hope, that what does the UHC law seek to do? First, it wants to clarify what does the DOH do and what does the LGU do in relation to the delivery of population-based services. And just to reiterate once again, population-based services are the services that are offered to persons, communities, and society in order to be able to prevent the spread of certain diseases. One that's very, very familiar to us is the COVID-19 vaccination. That is a population-based service because when you get vaccinated, you are not only preventing yourself from getting severely sick from the disease, but you are hopefully also preventing the other members, the other persons that you interact with from getting the disease. Whilst PhilHealth now will be the payer for the individual-based service. Admittedly, these delineations of population-based and individual-based, they're not cut and dried, meaning to say there are many services that span or straddle between population and individual-based. And that is still currently work in progress as to trying to see where the different services will fall into place. But definitely a very clear individual-based service is when one gets hospitalized, that person who is sick is the recipient of the care, and therefore that is individual-based, and that is surely to be paid for by PhilHealth. Of course, we've talked about a special health fund or the pooling of funds to PhilHealth for all individual-based health services. We hope to be able to take away the fragmented, sometimes double dipping is what they say. When people go to the social service, but they also go to PAGCOR and they go to PCSO to try and accumulate funds to be able to respond to their health needs. We're trying to, through the Special Health Fund as one of the measures that the UHC law is trying to put forward in order, why do we need to pool funds? So we can leverage. You know how it is that if you are the biggest buyer or payer, then you can leverage prices. And that is what we're hoping to do through PhilHealth. As I already mentioned, simplifying membership, direct and indirect contributors, and importantly, contracting networks that are based on adherence to quality, co-payment standards, third-party accreditation. Here, the recognition of the law is to state that public sector cannot do it alone. No matter how good and robust your public health system is in your province, in your cities, you cannot do it alone. And you need, and this is a global learning, that you cannot carry out universal health care, universal health coverage without the involvement of private sector. So contracting a network is seen to be an efficient way of doing it, and also is a way to ensure that a certain level of quality standards is achieved. And here I point out co-payment kasi nga, as I said, UHC does not mean everything is for free, but the level of co-payment is now being more negotiated and more appropriate than what it is right now, where people can charge whatever they want in a private setting. And of course, accreditation is important to ensure quality. And so what do we have? We have here local government units, provinces, and cities. And the two currencies that I like to say that are very relevant for under the Universal Healthcare Law, which I think, and based on our work and experience, are what are being talked about. Our work in Think Well brings us to the province of Antique and the province of Guimaras in Region 6. And the discussion always revolves around two things: the province or citywide health system and the special health fund. And so let me just talk about these very briefly. Here is an example of a healthcare provider network in the province of Antique. The province of Antique is relatively big. Therefore, they have 3 primary care provider networks, one in the north, one in the south, one in central. But they only have a secondary level hospital, the Angel Salazar Memorial General Hospital. They do not have an Apex hospital. An Apex hospital is the hospital that is being able to offer tertiary specialized care. There is no such thing in Antique. Here we can see also, we plotted this to be able to understand what was the lay of the land in Antique, who can provide services. And here there are private providers, TMCH, SMPH. I have to look at my código about who these are, but they are private providers, infirmaries and private clinics that are within the province. And these are seen to be where the flow is, beginning here with the patient who will first go to his or her primary care provider network, which consists of 6 rural health units and 3 laboratories and 23 pharmacies and 15 clinics and 82 barangay health stations. And they are networked. And when the cases are no longer manageable at the primary level of the RHU, then they move to a higher level, all the way to a level 1 hospital. But if the cases are really complex, we'll eventually have to move to the secondary level. And here, potentially, because this is not yet happening, potentially having to go to an Apex hospital, which would be in Iloilo City. But here you notice there is a lot of gatekeeping and triaging. Those that can be managed in a primary level, they stay there. That's cheaper, and there's closer monitoring that can happen. Those that cannot be managed will go to a higher level, but not necessarily immediately to the tertiary level or to the most sophisticated. Why is that so? This is expensive and irrational. If you go through the levels of referral, then you are able to make sure that the services rendered are on time and are efficiently done and rational. Of course, that is to assume that all of these facilities do comply with the standards required for accreditation and for ensuring quality. So this is just an example. And all of these are managed through a province-wide health system that is guided through a management committee in the local health board, led by the provincial governor, or in the city, in the case of cities, managed through the cities, led by the mayor, guided by the local health board, and hopefully a special committee that will oversee UHC implementation at the level of the province or the city. So what do we see here? What we see here are the special health fund coming from different sources. So we have here from the general appropriations that will enter through the national tax allotment to the LGU, as well as some few funds that will be coming, let's say, from the Department of Health or maybe other grants. And then there are also payments from PhilHealth for individually based services, all pooled into a special health fund and all accounted for at these different levels. And as I said, the private sector is being invited to also be part of the service delivery as well as the other functions of universal healthcare, managerial integration, but all will be paid out of the special health fund. And here, as I show you, the triangle here shows you the different levels of hospitals or facilities, health facilities rendering different services, and they are color-coded. So the green ones are public facilities and the red or pink ones are private facilities. And you can see here that everything comes from the special health fund. All services that are population-based coming, as I said, from national and local budgets, as well as individual-based services that come from PhilHealth payments, as well as other payments, like private health, hopefully will be pooled into the special health fund and will thus be the source for the payments to these different facilities for all the citizens within the catchment of the province or the city, managed under a province-wide or city-wide health system. And so what do we have? We have the Universal Healthcare Law, but we also now have Mandanas Garcia ruling. And I say that both are unique opportunities for us to be able to allow us to actually build on these two reforms as a way to be able to ensure that our citizens, our populations that we serve in our LGUs will actually grow closer to achieving better or good health outcomes without necessarily becoming poorer because of this. You already know this, that the Mandanas Garcia ruling, as you know, will mean that there will be larger amounts of money that will be given through the former ERA, now the NTA or the National Tax Allotment. And there will be a transfer also of responsibilities or functions to the local units, including the Department of Health. But of course, we cannot do this all in one fell swoop. So what will happen is that there is, first, of course, last year was the devolution preparation. This year is the devolution transition period. I assume that all of you here who are from LGUs have already submitted your DTPs to the committee. And EO 138, which is the executive order that mandates the full devolution as driven by the Mandanas Garcia ruling, will fully roll out in 2025. So how do we bridge UHC law opportunities and Mandanas Garcia ruling? And I propose the perspectives using health financing. I think that a lot of this is translated to funding or financing. And I propose three lenses, as it were, to use. First is resource mobilization or revenue generation, meaning how do your local health systems generate and collect revenues? Because this will be the source from which you will be paying out and contracting services. Second is pooling. How do we combine financial resources from multiple sources to share financial risk of paying for healthcare? And third, how do you pay your providers? So I propose this, and this is how I will present to you what we think are the opportunities and challenges. So again, UHC law increased premium rates. The law states that there will be gradual increasing in premium payments, especially for the directly contributing sector, so that these monies can be used to make the benefit packages more comprehensive and more expansive. Meanwhile, Mandanas Garcia says LGUs are to receive higher national tax allotment because of the bigger tax base from which these are computed. So there are opportunities here in resource mobilization. Then there's pooling, where the transfer of monies at national level to PhilHealth, consolidation to a special health fund. Mandanas does not speak much about this, but again, there's an opportunity for local government units to think about what will be gained with the pooling of funds as a leverage for better negotiation. And third is purchasing, where now the roles of DOH, PhilHealth, the local government units are clearer. Not crystal clear, I have to say, but there is an effort to try and define all of these. And most importantly, the biggest or one of the most important priorities of the universal healthcare law is primary care. And you've seen that, all of us who went through and are still going through the ravages of this pandemic, you can now see how truly, truly important a primary care facility and primary care providers is, because the delivery of the vaccines, the contact tracing, the education of the people, they are all primary care functions. And in EO 138, what does it say? There's lesser DOH support in the area of hiring, procurement, capital investment. And if you have a look at the DOH, the Devolution Transition Plan, they have a staggered way of transferring these services. So not to scare our LGU participants here, but eventually even the augmented hiring of personnel will eventually be transferred to the LGU because the DOH no longer has the funds for this. So in the arena of resource mobilization or revenue generation, you already all know this, there is potentially for 2022 a 55% increase in ERA or national tax allotment with these as the possible increases. Municipalities about 34%, provinces 23%, cities 23%, and barangay 20% of percentages of the national tax allotment that is to be given for 2022. What do we see here? There are opportunities. We give local governments a larger amount of predictable funding per year. Therefore, there is a larger fiscal space. There are many possibilities because there is a larger fiscal space. But as they say, to one that is given a lot of privilege, there is also a lot that is being asked. And that is the challenge. The challenge that we face is that the greater amount of funds that are not earmarked will also need to be accounted for. And here I speak now for the health sector that really local government units, you must think about ensuring and safekeeping or making sure that you already determine a percentage of your NTA that you will allocate for health. And there should be no negotiation about that. I do know that in the lower house of Congress, there are bills that are pending indicating a 15% of the NTA as a possible portion that should be allocated for health, because we need to do this and be accountable for it. That can be used for hiring of health personnel, procurement of commodities, capital investments. But we know that it is possible that none of the additional funds that will be released by virtue of Mandanas Garcia will be used for health services. And that for the longest time, many LGUs have been dependent, on central government, and also there is no assurance on how these funds are used, which are dependent entirely on the priorities that the LGUs have. And so, for example, there is unconditional cash transfer from the national government to the local government, 30 to 40% of tax revenues. So there is bigger amount of money. But for example, because of the pandemic, a provincial governor may really see and state that, yes, health is important. It should be a priority. And that even before, this happened, his province was doing very well for health. But there is also the dream of the provincial government to turn the province into a tourism destination. And this requires a lot of capital investment. So there is this pushing and pulling that if there is no earmarking of monies for health, it is possible that this will be deprioritized because of these other potential economic or livelihood opportunities that the province sees is the way for them to develop. So things to think about. I'm not saying it's wrong. I'm only saying that there must be a way to safeguard a certain portion to ensure that the health services are delivered in the manner and quality that they ought to be delivered. Next, in pooling, which is, as I said, the creation of the Special Health Fund. The Special Health Fund is a mechanism of integration, financial integration from the law, as I said, to consolidate funding pools. It's very hard if there are many, many funding pools that you are dealing with in order to be able to access health service. So the Special Health Fund is intended to serve as a funding pool for use of an integrated local health system, from which can be used for personnel, commodities, capital, investments, facilities. And here the picture just shows you actually, this is an illustration of how cities and provinces, are divided according to the size, the land size or population size. But here is another way of rendering how the monies can be pooled in a manner that will ensure a more efficient and more integrated way of paying for services through a Special Health Fund. And so what are some opportunities here? The Special Health Fund will reduce fragmentation or inefficiencies and can be used to finance health services and facilities at a local level, will create a financing mechanism that will ensure a functioning integrated health system, leveraging on the fact that it is the special health fund under a province or citywide health system, which is the leverage to be able to negotiate costs or prices with the providers, to will also be used to ensure that there is an appropriate, rational way of delivering health services, because they are the biggest payer. Right now, if you don't get it from here, you go to another source, you go to another source. But what will happen is the Special Health Fund will try to bring this all together. But there are also challenges, because since the enactment of the UHC law, an exceedingly small number of special health funds have been established, highlighting that there are managerial, political complexities of integrating fund pools currently held by many different local government actors. In addition, and I've just come from an ongoing forum that I'm moderating, where we're talking, we have speakers from the DOH and PhilHealth who are saying that because the Special Health Fund will consist largely of government money, it must go through the usual procedures that they need to comply with as mandated by the Department of Budget Management and Commission on Audit. And how does that then square with having to pay private sector from the Special Health Fund? So it is understandable, therefore, that it is challenging. And that's why many cities or provinces have not set up their special health funds. But I do know that in our two provinces, Antique and Guimaras, they've already set up, they've opened an account, but they yet are waiting for where the monies to put into the special health fund will be coming from. So again, I just show you this graphic to show you again what the special health fund will be used for and where it will come from. So again, national government subsidies, PhilHealth payments, grants from international partners, etc. And the LGU, from its national tax allotment, can also mandate a portion of this to be put into the special health fund. For after all, the special health fund will be used to pay for both population and individual-based services. And remember, most population-based services are delivered from public facilities. And therefore, these are the rural health units, the city health offices. And therefore, they will also be paid for through the special health fund, as well as other health system operating costs, capital investments, and payment for more health workers, and as well as the incentives for all health workers. So the third lens, which is purchasing, we know that because of EO 138, the Department of Health in particular will reduce the amount of non-financial support it provides to the LGUs, meaning HRH augmentation, the nurses, the midwives, the doctors to the barrios. They will eventually be transferred already to the LGUs and will no longer be supported by DOH. And therefore, the LGUs will have to rely on its own funding and capacities to take over these, which will include hiring of nurses and midwives, procurement even of some medicines and commodities. But mind you, this is not going to happen overnight. There is a devolution transition plan, and the DOH has already stated that there will be certain non-financial support services that they will continue to hold on to because they are just so important that they cannot be transferred to the local government units. And in addition, there are also certain criteria for the LGUs, so that LGUs that are really, geographically isolated or really have special contexts, they will not be part of the transition at this point. And so this is just a visualization. This is what you call a Sankey diagram, where we tried to visualize where the funds come from and where it's being used. And you notice here that there is a big portion that is supported by the central government revenues of DOH to pay for many public health services. There's even the SWD, and here are the local government funds. We simulated this to see and apply EO 138, and this is what's going to happen. When the full devolution really truly happens, this big square is going to go this small because the lower portion, which is the yellow square, will become much bigger and will then be the main payer for all public providers' services, particularly for staff salaries. So again, there is opportunity here. Local government units, as really in the real intent of the devolution, local governments are led towards greater autonomy in how they will spend their money. In the hands of good political leadership, these additional funds and functions can be used to effect clinical managerial integration, which is very context specific. You see different situation in your city as opposed to maybe another situation in even a nearby city. And therefore you can really contextualize and customize how you will design your health programs. But there are challenges as usual. We've been so accustomed and been so dependent on the DOH for this kind of support that many LGUs do not have the experience and the capacity to shoulder some of their expected responsibilities. And that is why forums such as these, Livable Cities forums, are very helpful to get the LGUs to start thinking and innovating how they will be able to approach this. But it's a little step at a time. It cannot be big leaps altogether. But for example, there are commodities, and this could also mean expensive goods if the economies of scale is lost. So how do you then deal with this so that you can maybe network with other cities who have or share the same needs as yours? I'll skip this because this is just an example again of a provider network. So again, an example for the challenges. We have, and this is a real life situation, a local municipal health officer has only a low budget for health, but he knows that he has to make a good case to mayor and the local health board. And a good plan and budget is crucial for this. But poor MHO, he does not even have the data that he needs to project what his needs are. And he has only few staff and in many cases lacking in necessary training. I'm just highlighting here realities on the ground that sort of express how these challenges are to be addressed. Just to summarize, for the UHC law and the Mandanas ruling in the area of resource mobilization or revenue generation, pooling and purchasing, these are the challenges. For now, there is no guideline, there is no directive that you should earmark for health. And there are accountability measures. You already know that with a big amount of money that would be given to your LGUs, you have to be held accountable for that. Of course, we are looking forward to our local chief executives who will prioritize health because health is truly fundamental to life, and possibilities that funds will not be used for health is real, especially if there are conflicting or competing forces for these funds. In the area of pooling, support or commitment, of course, from the local leadership is very much required. We cannot help this, but these are realities on the ground. When money is talked about, there is also the dimension of rivalry and trust, and of course, the need to align with our national agencies. And in the paying for these services or purchasing of these services, we've been so accustomed to being so dependent on the DOH. If there is a need, we go to DOH, they send augmentation, etc. We do have, weak capacity to plan, to procure and hire. We're not very adept at that in the local government. Possible loss of economies of scale when we need certain commodities, like commodities for sexual reproductive health or family planning. And we need to align also the roles, all of these with DOH and PhilHealth. But there are also opportunities. The funds that will be given or are given by virtue of Mandanas Garcia. The Special Health Fund, it is, no matter how difficult it is, it truly is an opportunity that needs to be prepared for and studied in order to be able to take advantage of what it can possibly do. And again, purchasing will allow local government units to really customize and contextualize what the needs are of their constituents and be able to identify the appropriate services for this and pay for these services as well. And so in the end, how can we take advantage of these opportunities that are brought about by UHC law and Mandanas Garcia? Here, knowledge is truly power. Knowledge management, information is key. We need to have the systems to get the data and manage whatever information we should have. We should put this as really a basic foundational system work that must happen in order that you are able to make the decisions and also determine that the proper funds are allocated for the needs, especially for the health needs, but not only for the health needs, for the different priorities that confront a local government unit. And what can knowledge do? It can allow you to perform better budget utilization. Budget utilization, as you know, is your ability, local governments, to allocate the funds appropriately. All the steps from budget formulation or budget planning, budget implementation, budget monitoring, all of these steps are needed so that you can allocate, obligate, and disperse the funds correctly. But knowledge is needed for you to do that, so that you need to be able to do good planning, good execution, and determine in all of these competing interests and priorities in our local government, where and how do we allocate the funds. And third, absorptive capacity. It's one thing to make a beautiful budget, but it's another to make sure that the monies are used and used well and used efficiently. And this is what absorptive capacity is. It describes whether the funds are used in an effective manner in the fulfillment of goals and objectives of an office. Here is where you can measure whether the funds that have been given to you are truly translated to attain your performance indicators. So for example, the budget allocation said that we need to be able to purchase X amount of vaccines. The absorptive capacity there is to know that, yes, we have the vaccines, but do we have the people to be able to inject these vaccines? Do we have the wherewithal to actually reach out? Or else, indeed, you had a beautiful budget and you were able to allocate according to need, but the absorptive capacity is poor. And these two are largely based on how, where, and what kind of information you are able to access within your local government units. And so, in summary, the UHC law, EO 138 through Mandanas Garcia, they portend changes in the local health system structure. And there are major changes, not only in local health systems, but also in the national government, because integration is seen to be the key, the currency by which we carry out UHC through a province or citywide system, and the special health fund that accompanies it. We already know that such an opportunity is augmented by the additional funds that will be received from the NTA. And second, local governments can expect an increase in their decision space because of the changes from the UHC law and EO 138. And third, of course, ongoing challenges of local leader priorities, absorptive capacity issues will determine whether the increased decision space will actually lead to improved financing and services. And here again, I reiterate, data, knowledge is key, and information is crucial to be able to carry this out well. We take baby steps, we take it a little at a time, but these are truly great opportunities for local government units. Maraming salamat po for listening, and happy to take any questions. Thank you very much.
Thank you very much, Marife. Excellent presentation. I think you really outlined the opportunities, the challenges, the great potential, and the great potential pitfalls that we have. And I think, the challenge now is in the implementation. How do we make that transition as smooth as possible? Because I'm sure there are going to be bumps and hiccups along the way. But thank you for that. And I think, we've learned a lot from your presentation. At this stage, let me invite all our speakers back on screen for the open forum. We have Dr. Gabriel Borlongan from the Health System Strengthening Division of the Department of Health. We have Dean and Center Director Vicente Belisario from the College of Public Health, UP Manila. Dr. Ryan Lee, the Senior Health Systems Advisor, the NHS Consortium for Global Health from UK. And of course, Dr. Marife Yap, Senior Technical Advisor for ThinkWell. And we have a lot of questions, so let me go right to the Q&A box. No? Okay, let me start with the first question. Will LGUs be building their own digital systems, or will there be a common best practice digitalization system to be provided by DOH or a central unit? Maybe let me start with Dr. Gabriel Borlongan to give us your take. What's DOH going to do? Centrally provide or let them build their own?
Yes, for the DOH, there are already information systems available, particularly electronic medical record systems that LGUs or even private sector could adopt, but they have the freedom to choose whichever system that they will be adopting, provided that it is compliant with the National Health Data Standards. Over.
Yeah, so, okay, let's say, you know, we've seen this happen in contact tracing, so forgive me if I'm a little nervous about that approach. Everybody built their own contact tracing system and they were not interoperable, and so contact tracing never really worked. So if you allow, Dr. Gabriel, if DOH allows LGUs to build their own systems, how do we ensure that there's going to be some sort of interoperability of data?
Yes, for that, they started with setting up the National Health Data Standards. So for an EMR to be electronic medical record system to be accepted for use, it should be compliant with the standard so that this will enable interoperability.
Okay, now here's a question I'll toss to Dr. Belisario and to Dr. Yap, no, Marife Yap. Is there a specific policy and environment change that would help integrate innovative solutions while strengthening health systems? So I think by having LGUs, many LGUs work, on their own, we can have a lot of innovation. On the other hand, how can we make sure that the innovation is very integrative or integrated? Dr. Belisario, maybe we'll start with you.
Thank you, Mr. Luz. I think leadership is key here. No? I think leadership must provide the framework, the stage on which the integration, the partnership and collaboration must happen. I'm afraid if there is no such overall framework dictated by our national health leaders, a decentralized health system gives you variable levels of capacity and variable ways of doing things. And so you look at the whole system, some score, some don't, some score big, some score low. And therefore, the framework, I think, Bill, will need to be provided by national health leadership. Of course, guided by experts. When WHO works, it's not mainly just WHO calling the shots. But WHO convenes experts to advise WHO so that it can guide governments. Now, I think Department of Health is doing it, but we need to do it more on a regular, more consistent basis. We call that expert panels advising Department of Health, providing the framework needed for such a stage. Over, Bill.
Okay. Yeah. Thank you. Thank you, Dr. Belisario. Marife, what's your take on this?
Yeah.
Innovation, integration, how does this work?
Yeah, I agree. I agree first with what Dr. June Belisario said. Of course, leadership is key here. But I just like to go a little bit more granular or also some practical worries. First, there are about 58 UHC integration sites. These are sort of the test cases, so to speak, of trying out the different UHC policies. Although that's still a little bit limited in that it can be innovative, but it still must fall within the guidelines of government. There is that arena. But what is needed there, as Dr. June said, there has to be the leadership buy-in to say, yes, health is important. And this, the one that gives that mandate is precisely the devolution. The devolution of health services in 1991, and then now further pushed with a full devolution from an EO 138. That, in a sense, that's why even the UHC law will state that the LGUs may or may not actually choose. No, there is that opening because the devolution, the local government code must be reconciled also with how this will align with the UHC law. So I'm saying that there are these little pockets of being able to look at innovation. And then third, what I wanted to say was because you need to study how to be able to integrate these innovations, it's really partnering with organizations and schools, academia, to be able to provide the thinking about the options and the scenario building, which we know because the LGU plates are so full, they don't even have the time anymore to think through that. No? And this bill happened, as you know, with the teeth we work with COVID. The thinking was done sort of external a bit to government, but what delivered to the doorstep of government. These are areas that can be explored for inclusions of learning of innovations that need to also be written out and stories to be told. Over.
Yeah, no, thanks. And that's a good point you brought up, Marife, because I think there's got to be a role here for private sector somewhere. So let me ask Dr. Lee. Dr. Lee, are you online with us? Thank you first of all, and thank you first of all, and thank you for allowing us to get you up a little bit early in London to take on this webinar and to answer questions and to give a presentation. So thanks. So on the NHS side, I have two questions for you. Is it, how is it funded? Is there a contribution from UK citizens and residents, or is it just picked up strictly through taxes? And second, in the delivery of the service, is there a role the private sector plays in the delivery of the health service?
Yes, I'll take your questions in turn. So the UK National Health Service is entirely government tax funded. So both through, it's really through general taxation. We do have a line item in our tax when our salary comes through called the national insurance, but really that's another kind of income tax where the threshold is slightly different. So in short, it's kind of general taxation. On your second question, the role of private providers. So private providers accounts for, or rather privately paid care accounts for a very small proportion of UK healthcare. So it's definitely less than 10%. I don't know the figures offhand, but if I recall, it's something less than 5%. So very small amount. So the really vast majority of care is provided or funded rather by the state and provided by the state. And really that speaks to kind of, and I think that's quite unusual actually in many countries in the world. The UK has chosen to do it this way since it after the Second World War, the state decided that there would be cradle to grave care for all citizens. That's funded and provided by the public sector. Having said that, in recent decades there have been many reforms in the NHS, and there is an element of a so-called internal market where for a state, let's say for a particular service in a particular community, may be open to bidding from different providers, which may include some private providers. So now we are starting to see some private corporations kind of bid and win the tender for providing the service funded by the NHS to provide healthcare services to the specification of the public NHS. So kind of it's starting to get quite murky in this sense, and there are ongoing reforms. So it's quite a complicated picture, but I probably not as fragmented as in the Philippines, but because at least it's fairly centralized still. yeah, but kind of that's a big picture really. Mostly it's state funded and public provision.
Okay, thank you. Let me ask a little bit then for the others. Dr. Gabriel and Dr. Belisario and Marife, yeah. Let's say, if I understood it correctly, the funds for the payment of our universal health care will come from a combination of the national tax allotment. So my first question would be that, do we expect a continuing contribution from private citizens? Will that still be a requirement for us as taxpayers? Separate from tax, huh? I'm talking separate from tax.
Let me begin. Just to clarify, Bill, a private contribution separate from tax in terms of what? Paying for health services, you mean?
Yes, yeah. So obviously our taxes are going to contribute towards the
yes.
Towards the NTA, the allotments, right? So
yes, yes.
On top of that, are we still required to pay PhilHealth, for instance?
Yes. As you know, there are only two types of membership now in PhilHealth, the direct contributors and the indirect contributors. So the direct contributors, which largely consists of a lot of the formal sector, will have to continue, and there will be increments of increases in premium payments so that we can really cover for more benefits. And also the indirect contributors that are paid for through sin tax and alcohol beverage taxes, they will also have to contribute. But in addition to that, when you access health services, because our system is not totally like the United Kingdom or other European countries, there will still be the possibility for people who want to get more services or want better accommodation who will need to pay out of pocket. But what the UHC law is assuring is that the basic set of services that are responsive to the needs of the majority should be paid for totally through a social health insurance program or through the UHC law. Over.
Okay, so I have a question for the others, for Dr. Gabriel. For instance, okay, so the allocation goes to the provinces and the cities, the LGUs. I suppose it must be prorated to perhaps population at the very least. Now, what recourse do we have if we live in a province which received the money but is unable to really provide the healthcare services effectively? Because I'm not sure every province or every city can provide an equivalent level of health service. What happens in that case? What recourse does a patient have? Can they move to another jurisdiction to get treatment? And will that be covered?
To answer that question, there could be two perspectives. So first, I'll look first for the perspective of the LGU. So regarding the support that they could be provided with, so it will be examined after monitoring of the performance by the national government. So for health, it would come from the Department of Health on what specific assistance, whether it be technical or financial, that has to be directed to them in order to better serve their population. Now, on the more practical perspective of the patient, so there is no limitation as to where a patient would want to seek care, but there will be, or possibly there will be some circulars or issuances later on regarding how primary care could be streamlined and further strengthened, and whether or not shopping or going to different clinics that are not you are not registered with, that will be some part of discussions later on. Thank you.
Okay. Dr. Belisario, what's
your take on that?
Yes, if I may add, in addition to that, I think oversight also will be key here. And that's the role of national government, the Department of Health. And oversight includes, of course, providing the seal of quality as a guarantee that services being offered comply with a certain minimum. specifying, for instance, levels of accreditation to justify the kind of services that are offered there that will be paid for by social health insurance. And as such, oversight has to be strong, at national level, with, of course, deputization of regional offices, perhaps, because not one office in central government can do the oversight. Together, of course, with partnership. No, we do not discount the possibility that with so much burden to oversee and regulate, and review policy and continue to review policy, implement policy, national government, DOH will need that kind of partnership as well. Over, Bill.
Yeah, thank you. So I guess, Dr. Berlongan, you're saying the DOH should monitor the performance of these different hospitals, no? Now, what happens then to your district hospitals, your CHDs? And in a case where,
I think you froze, Bill. Secretariat, I think Mr. Luz is having connection problems.
Yeah.
There you go. We lost you, Bill.
Oh, sorry. I'm sorry. Dr. Berlongan, I was asking, what happens to the, you have the local LGU and the provincial hospitals. What happens to the district hospitals? Do they remain with DOH? Or is the plan to make sure every province has a tertiary hospital? Because if you don't have a tertiary hospital and a patient needs to transfer, will his cost and, the cost of care be transferred as well to that new hospital in a different jurisdiction, a different province?
Yes, there's a Philippine Health Facility Development Plan which sets out the areas and type of facilities that has to be invested in for the next 10 or so years. So that plan, which was a result of a study, showed that we first must invest in primary care facilities and then the level 1 hospitals. So actually, it was the higher level of care are relatively more abundant compared to primary care. So that is the trust of the nation based on the law and on studies.
Thank you. Let me ask a little bit about this, about health information. There's a question here about the health information exchange. What is the status of that right now?
I'm not completely aware of it, but right now the National Health Data Repository is being set up so that this could be the funnel of all health-related data for both DOH and PhilHealth. But let us take into account we are a nation of 100 million, and even the countries that have similar kinds of population or even smaller have challenges with this. So in terms of health information system strengthening, it would be a progressive rollout.
Mm-hmm. Thank you. We have really so many other questions in our Q&A box, and I'd love to continue the discussion, but we're running a little bit over time already. So first I want to thank our speakers this afternoon, Dr. Berlongan, Dr. Belisario, Dr. Marife Yap, Dr. Ryan Lee, for your presentations today. I think we learned a lot about how to, implement universal health care, what challenges and opportunities there are. And also, I think going back to Dr. Lee's presentation, that there's an opportunity to learn from each other from city to city, not only city to national government or country to country, as their experience shows it with the UK Better Health Project. So thank you for all your presentations. And at this stage, let me call on our partner for today, Ina Murillo from the British Embassy, to deliver her closing remarks. So Ina, good to have you on board again. Over to you.
Hello, hi Bill. I'm Asuke in this in these sessions. So to our very generous speakers who share their analysis, experience, and even enlightening pathways out of frustrating scenarios in the health space to come back to a common ground, whether through SDGs, Ambition 2040, or existing agreed frameworks. Very many thanks to everyone joining in. I think we had about 150 earlier in the Zoom call and others joining in over Facebook Live who found time to learn and engage in this discussion. Despite the many demands wherever you are in Mindanao, Visayas, Luzon, or waking up early in the UK, a very pleasant afternoon to everyone. Sana ay nasa magandang kalusugan tayong lahat. I'm Ina Murillo. I head our socio-economic development work, the UK's development support to the Philippines, primarily through our portfolio of prosperity programs, where we have our Better Health program. I want to thank our speakers, Dr. Berlongan from DOH, describing the opportunity from EO 138, and better understanding of devolution and the wider socioeconomic factors that interplay, enabling healthy cities for citizens. Dr. Yap for helping us better understand local health ecosystems, its gaps, opportunities, efficiencies, and how we can best use that for direct health service delivery and where data is key. Dean June, of course, our very close partner, extending the great columns of the UPCPH to critical fora such as this, and underscoring the need for more partnerships and collaboration, as well as capacity building, describing the wider enabling community for public health. And Dr. Ryan, I think Ryan is in the car right now, starting from our first conversation with him and his team in Thailand, I think 3 years ago. He's been bursting with amazing insight and international expertise that enabled this honest-to-goodness health development work in our Better Health program and model global health partnerships. Very many thanks again to our speakers. Earlier this month, I went to Iloilo with Liz, our very able health advisor at the embassy, along with our delivery team to meet our Better Health program stakeholders in the region. That's after almost 2 years of virtual delivery. The series of meetings and engagements to challenge sustainability of our humble interventions and support made me reflect that in an ideal world, there should have been a pause of some sort. There should have been a moment for us to stop first, look at our COVID response, and where do we mark actual recovery phase. It would have been great to have a moment to take a step back, realign, recalibrate, assess our capacity on the ground and new opportunities as greater financial independence come along with the EO 138. But there isn't. That's the reality. There is often no breather in between designing program solutions and implementing immediate needs, especially for health and especially in this critical COVID recovery. I don't think frameworks and flowcharts ever truly capture the in-the-moment innovations that we have to take on in such unprecedented challenges. And our policymakers at the LGU level know that more than anyone. I'm deeply humbled that most of you in the call now go through suboptimal situations day in, day out, stretching your time, patience, and every ounce of creativity and commitment to deliver quality health service despite limited means. In the country, we recognize that this has been more acutely felt in public health and for local governments with expanded responsibilities in ensuring health security, resilience, and recovery. But throughout these challenges over the last 2 years, we have also seen how agile and responsive partnerships have helped us respond to emerging challenges throughout this pandemic. The local and global partnerships are gold, and these provide hopeful and helpful pathways to move forward, learn from each other, and embrace a community committed to getting the job done and done well. Against this global health challenge with acute local consequences, I would like to extend the UK's continued commitment to health development in the country and the region. Through prosperity programs, we have extended technical resources and opened opportunities for collaboration, like the Global Health Program, through which we had set out an ambition to establish a global community of shared learning and practice in public health across borders, areas of expertise, and disciplines. This also enabled us to work more closely with the UP College of Public Health under Dean June's admirable steer, the DOH Bureau of International Health Relations, and LGU's Pasig City and Iloilo City. As pilot, I am pleased to have the NHS Consortium for Global Health in this afternoon session through Dr. Ryan. The NHSC has helped the UK Better Health Programme establish valuable technical linkages between public health bodies in the UK and the Philippines, providing expertise, resources, lessons from the UK's 70 years experience delivering UHC through the National Health Service and its public health ecosystem. To complement this program, through invaluable learning channels, this Healthy Cities project, co-organized with the amazing Livable Cities Challenge network, has delivered direct impact towards this ambition. LCC has championed cross-sector collaboration between the public and critical private sector by enabling collaborative dialogue to share best practice, challenge, and innovation across varied contexts of UHC delivery, pandemic resilience, and local governance. And on this end, I would like to thank Bill Luz, his team, and the Livable Cities Challenge Network for participating in the three-part learning exchange for local governments in partnership with the League of Cities. This has helped expand the reach of learning exchanges critical in this time and establish a wider community of key stakeholders with a shared vision. While this is the closing session of the Healthy Cities series, we hope this continues to encourage similar dialogue and learning exchanges among local governments across the country and internationally between the UK and the Philippines. It is not so much just sharing of the slides or links, but the overflowing goodwill and commitment to basic good anchored in all our shared commitment in the Philippines and wider. I close by reflecting on the second poll question from Bill. How ready are LGUs at this point for devolution of health and basic services? The 50-50 response feels very much like a fork in the road representation where political will shifts the dial between defining the moment as an opportunity or a challenge for UHC. This crossroads, as in many concerns around health, demands informed decision-making based on data and critical analysis, and this demands commitment from all key stakeholders, public, private, academia, and an empowered citizenry. Because after all, if the pandemic has not underscored this lesson enough for all of us, the challenges now have become more complex indeed, moving beyond an arm's length agency type of solution alone. The solutions now go beyond borders and take on a more open, inclusive, and more discerning data-driven call to action, enabled by this same community representation that will move mountains and seas to be able to actualize genuine better health for all. Maraming salamat po. Thank you very much for this afternoon session. Thank you, Bill.
Thank you, Ina. When you reflected on the 50% yes, 50% no, are you ready question? I guess I would see it as a bit on the positive side. The cup is half full, because if I were to backtrack exactly 2 years ago this week to the beginning of the pandemic, when we just entered lockdown around mid-March. If you ask people, are we ready for a pandemic? I think the scores would not have been 50-50. The no's would have probably been much, much higher. And it shows how much we've learned over time. So I think it's a good start, but our speakers today have added so much knowledge and insights to our LGUs that I think it's going to be a very helpful exercise for everybody. And also, I must say from experience, there never is a breathing spell for anybody. We seem to move from one emergency to another, whether it's a national emergency, a local emergency, or an international emergency. There's always something happening in the world. So we have to remain agile and always just be ready for very little breathing space. But nonetheless, it's good to take time today to learn. And I want to thank everybody for spending their afternoon with us and to thank all the speakers. Now that we're moving to alert level 1 across more parts of the country and travel is opening up, our next topic for the Livable Cities Lab is going to be on travel. We'll do that in April 27th, talk about revenge travel, the post-pandemic tourism boom that we foresee. And Ina, I just came from Iloilo over the weekend, and people are up and about. And I take that as a sign that people feel safe and people feel healthy to be able to go out a lot. And I see a lot of the places are full and a lot of people are up and about. So I think that's a great sign. And as I said, working, experiencing what's happening in Pasig and Iloilo, I think the UK Better Health team is doing a great job in both those cities. So on behalf of our partners, UK Embassy, League of Cities of the Philippines, Globe Telecom, for Livable Challenge Philippines, thank you for joining us for this lab today. We look forward to seeing you in our future labs. Thank you very much. And we invite you to fill out the feedback form as you leave this meeting. You will see it immediately when you exit the meeting. If you're on Facebook, just take a picture of the QR code and you will get the feedback form as well. Thank you very much. And we look forward to seeing you at our next lab. Enjoy the rest of the day. Thank you. Thanks, everybody.